Okay, getting ready here, folks. Getting ready. Okay, so here I want to talk about gender confusion.
Yo,
Coach.
All right. All right. I think we're going now. I think we're rolling now. We should be streaming on YouTube here, and we should also be on the stereo app. So, not sure if this is going to work out, but I'm trying it. I'm trying it here, folks. So, let's look at what do we got here? So, this article, Focus on the Family, answering questions on genetic confusion. Let's see here. And where's the part? Da, 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 da. Here we go. What is the best course for helping children who are gender confused? It should be remembered that very few children who demonstrate gender confusion behavior continue to do so into their late teen years or early adulthood. Most grow out of it and learn to live well in their masculinity or femininity. This fact also speaks against a biological foundation. Well, does it really? But does it? Because they're saying right there, most people will grow into their masculinity or their femininity, meaning their biology, right? Um, so I wanted to show you that article right there. Focus in the family. And then I want to talk about a couple other things here. So this article has the audacity to state that suicide risk is reduced by 73% in transgender non-binary youths with gender affirming care. Well, let's look at this a bit, shall we? Transgender and non-binary youths have a particularly high rate of poor mental health outcomes compared with their cisgender counterparts. According to investigators, these disparities are likely a consequence of social rejection, lack of support from parents, bullying, and discrimination. Multiple sources of previously published research found medical gender affirming interventions to be helpful in improving the quality of life for transgender and non binary youths by decreasing rates of long term mental health adverse outcomes. So, right here, multiple sources of previously published research. Funny they don't cite those. However, despite the existing evidence, legislation criminalizing and subsequently limiting access to gender affirming medical care for minors is increasing across the country. A team of investigators led by Diana Tordoff, this woman, MPH, Department of Epidemiology, University of Washington, examined the changes in mental health in youth after receiving care. Isn't that interesting? An epidemiologist, not a psychologist. Hmm. The impact of gender affirming care. Investigators said that previous data showed gender affirming care hormones, puberty blockers, and gender affirming surgeries have been found to be independently associated with reduced depression, anxiety, and additional adverse mental health outcomes. Puberty blockers administered during puberty can actually reduce suicide risk in this population. A decreased lifetime incidence of suicidal ideation was found among adults who received access to puberty blockers during adolescence. Once again, not citing a study. Investigators wanted to better understand the effect of gender affirming care on mental health immediately following the initiation of care. Given the high risk of suicidality among transgender and non binary adolescents, there is a pressing need to better characterize mental health trends for TNB youth in gender affirming care. TNB, transgender and non binary. Um, Understanding transgender and non binary youth. A prospective observational cohort study was performed to examine transgender and non binary youth who sought care at Seattle Children's Gender Clinic, an urban multidisciplinary gender clinic. Investigators, first of all, I want to say, that's interesting. A study was done at a gender clinic, not at a hospital, not at a non-bias hospital, but at a gender clinic. Like, where do they make most of their money at a gender clinic? Okay. So investigators evaluated the changes in mental health over the first year of receiving puberty blockers and or gender affirming hormones to see if they impacted depression, anxiety, or suicidality. So they observed these people for 1 year. So what they're trying to tell us here is that nothing bad's going to happen after the first 12 months. Huh. Main outcomes were measured with the patient health questionnaire, 9-item PHQ-9 and generalized anxiety disorder, 7-item in parentheses GAD-7 scales. Generalized estimating equations were used to assess change from baseline in each outcome at 3, 6, and 12 months of follow up, and nothing longer than 12 months. So this is not a longitudinal study. This is 1 year. Okay. Among the 104 youths, 13 to 20 years who participated, 63 were trans masculine individuals, 27 trans feminine individuals, 10 non binary, um, and 4 that did not respond to the gender identity question. At the baseline, more than half the individuals had moderate to severe depression and half moderate to severe anxiety. Self harm or suicidal thoughts were reported by 45 individuals. By the end of the 12-month follow up, 69 individuals received puberty blockers, gender affirming hormones, or both. 35 youth hadn't received either intervention. While there was no association found between these interventions and anxiety, investigators found promising results. Because they want it to be promising, I'm thinking. So you can see this paragraph here. They're just talking about the statistical variation, right? So in the conclusion, investigators focused on the need to address anti-transgender legislation and the additional need for medical systems and insurance providers to decrease barriers and expand access to gender affirming care. The association with the highest adjusted gross adjusted odds ratio, where the decrease in suicidality, which is important given the mental health disparities experienced by this population, particularly the high levels of self harm and suicide. Investigators wrote, "Our findings have an important policy implication, suggesting that the recent wave of legislation restricting access to gender affirming care may have the significant negative outcomes in the well being of the transgender and non binary youth." So that's the narrative that we're all used to hearing, right? That you got to do this, that we want to do this, that this is the kind and loving thing to do to to help people live a happier life and to reduce suicide rates. Well, now let's look at an article from the Heritage Foundation. Sex reassignment doesn't work. Here is the evidence. And this is from Ryan T. Anderson, PhD. Let's see here. Sex reassignment surgery. Sex reassignment doesn't work. It's impossible to reassign someone's sex physically, and attempting to do so doesn't produce good outcomes psychologically or psychosocially, excuse me. As I demonstrate in my book, When Harry Became Sally, responding to the transgender moment, the medical evidence suggests that sex reassignment does not adequately address the psychosocial difficulties faced by people who identify as transgender. Even when the procedures are successful, technically and cosmetically, and even in cultures that are relatively trans friendly, transitioners still face poor outcomes. Dr. Paul McHugh, the University Distinguished Service Professor of psychiatry at Johns Hopkins University School of Medicine, explains, transgendered men do not become women, nor do transgendered women become men. All, including Bruce Jenner, become feminized men or masculinized women, counterfeits or impersonators of the sex which they quote unquote identify. Um, in that their in that lies their problematic future. When the tumult and shouting dies, it proves not easy nor wise to live in a counterfeit sexual garb. The most thorough follow up of sex reassigned people, extending over 30 years and conducted in Sweden, where the culture is strongly supportive of the transgendered, documents their lifelong mental unrest. 10 to 15 years after surgical reassignment, the suicidal rate of those who had undergone sex reassignment surgery rose to 20 times that of comparable peers. Hugh points to the reality that because sex change is physically impossible, it frequently does not provide the long term wholeness and happiness that people seek. Indeed, the best scientific research supports McHugh's caution and concern. Here's how The Guardian summarized the results of a review more than of more than 100 follow-up studies of post-operative transsexuals by Birmingham University's Aggressive Research Intelligence Facility. The Aggressive Research Intelligence Facility. Jesus, that's all right. Sorry about the noise there. Here's how The Guardian summarized the results of a review of more than 100 follow up studies of post operative transsexuals by Birmingham University's Aggressive Research Intelligence Facility. The Aggressive Research Intelligence Facility, which conducts reviews of healthcare treatments for the National Health Service, concludes that none of the studies provide conclusive evidence that gender reassignment is beneficial for patients. It found that most research is poorly designed, which skewed the results in favor of physically changing sex, excuse me. There was no evaluation of whether other treatments, such as long term counseling, might help transsexuals or whether their gender confusion might lessen over time. And that's the big one. That's the big one that should be evaluated, right? Will counseling help? And does the confusion dissipate over time before we just decide to go on board with giving the, big pharma a bunch of money and messing with people's lives? There is huge uncertainty over whether changing someone's sex is a good or a bad thing, said Chris Hyde, the director of the facility. Even if doctors are careful to perform these procedures only on appropriate patients, Hyde continued, there's still a large number of people who have the surgery but remain traumatized, often to the point of committing suicide. Of particular concern are the people these studies lost track of. As The Guardian noted, the results of many gender reassignment studies are unsound because researchers lost track of more than half of the participants. Indeed, Dr. Hyde said the high dropout rate could reflect high levels of dissatisfaction or even suicide among post operative transsexuals. Hyde concluded the bottom line is that although it's clear that some people do well with gender reassignment surgery, the available research does little to reassure about how many patients do badly, and if so, how badly. The facility conducted its research back in 2004, so perhaps things have changed in the past decade. Not so. 2014, a new review of the scientific literature was done by Hayes Incorporated, a research and consulting firm that evaluates the safety and health outcomes of medical technologies. Hayes found that the evidence on long term results of sex reassignment was too sparse to support meaningful conclusions and gave these studies its lowest rating for quality. Statistically significant improvements have not been consistently demonstrated by multiple studies for most outcomes. Evidence regarding quality of life function in male to female adults was very sparse. Evidence for less comprehensive measures of well being in adult recipients of cross sex hormone therapy was directly applicable to gender dysphoric patients, but was sparse and or conflicting. The study designs do not permit conclusions of causality, and the studies generally had weaknesses associated with study execution as well. There are potentially long-term safety risks associated with hormone therapy, but none have been proven or conclusively ruled out. And that's what I'm saying. More will be coming down the pipe in the years to come. This has not been studied for a long enough time to know the the negative outcomes. Continuing on, the Obama administration came to similar conclusions in 2016. The Centers for Medicare and Medicaid Services revisited the question of whether sex reassignment surgery would have to be covered by Medicare plans, despite receiving a request that its coverage be mandated, in refusing on the grounds that we lack evidence that it benefits patients. Here's how the June 2016 proposed decision memo for gender dysphoria and gender reassignment surgery put it. Based on a thorough review of the clinical evidence available at this time, there is not enough evidence to determine whether gender reassignment surgery improves health outcomes for medical beneficiaries with gender dysphoria. There were conflicting, in parentheses, inconsistent study results of the best designed studies. Some reported benefits while others reported harms. The quality and strength of evidence were low due to the mostly observational study designs with no comparison groups. potentially confounding, and small sample sizes. Okay, so let me reread that sentence. The quality and strength of evidence were low due to the mostly observational study designs with no comparison groups, potential confounding, and small sample size. Many studies that reported positive outcomes were exploratory type studies, in parentheses, case series and case control, with no confirmatory follow up. The final August 2016 memo was even more blunt. It pointed out overall, the quality and strength of evidence were low due to mostly observational study designs with no comparison groups, subjective endpoints, potential confounding, which is a situation where the association between the intervention and the outcome is influenced by another factor, such as a co intervention. Also, sample sizes, lack of validated assessment tools, and considerable loss to follow up. That loss to follow up, remember, could be pointing to people who committed suicide and they could not track down. And when it comes to the best studies, there is no evidence of clinically significant changes after sex reassignment. The majority of studies were non longitudinal, exploratory type studies, in parentheses, i.e., in a preliminary state of investigation or hypothesis generating, or the studies did not include concurrent controls or testing prior to and after surgery. Several reported positive results, but the potential issues noted above reduced strength and confidence. After careful assessment, we identified 6 studies that could provide useful information. Of these, the 4 best designed and conducted studies that assessed quality of life before and after surgery using validated, albeit nonspecific, psychometric studies did not demonstrate clinically significant changes or differences in psychometric test results after gender reassignment surgery. So they're saying even with the 4 studies that were best carried out, there was no significant advantage to gender reassignment surgery. In a discussion of the largest and most robust study, the study from Sweden that McHugh mentioned in the quote above, the Obama Centers for Medicare and Medicaid Services pointed out the 19 times greater likelihood for death by suicide and a host of other poor outcomes. The study identified increased mortality and psychiatric hospitalization compared to the matched controls. The mortality was primarily due to completed suicides, 19 to 1 fold greater than the control group. Um, but death due to neoplasm and cardiovascular disease was increased from 2 to 2.5 times as well. We note mortality from the patient population did not become apparent until after 10 years. So once again, I remember I was talking about that first study I was reading. They were saying that it lasted for a year. Well, here they're saying right here, we note mortality from this patient population did not become apparent until after 10 years. So that first study I read is completely bogus because it only was carried out for a year. They didn't do any follow up. The risk for psychiatric hospitalization was 2.8 times greater than in controls, even after adjustment for prior psychiatric disease, which is 18%. The risk for attempted suicide was greater in male to female patients, regardless of the gender of the control. Further, we cannot exclude therapeutic interventions as the cause of the observed excess morbidity and mortality. The study, however, was not constructed to assess the impact of gender reassignment surgery as per se. Okay, continuing on. These results are tragic and they directly contradict the most popular media narratives, as well as many of the snapshot studies that do not track people over time. As the Obama Centers for Medicare and Medicaid pointed out, mortality from this patient population did not become apparent until after 10 years. So, any study that's not tracking these people for 10 years or more is completely bogus. So, continuing on. So, when the media tout studies that only track outcomes for a few years and claim that reassignment is a stunning success, there are good grounds for skepticism. As I complain in my book, these outcomes should be enough to stop headlong rush into sex reassignment procedures. They should prompt us to develop better therapies for helping people who struggle with their gender identity. And none of this even begins to address the radical, entirely experimental therapies that are being exacted upon the are being directed at the bodies of children to transition them. Sex change is a physical impossibility. We've seen some of the evidence that sex reassignment doesn't produce good outcomes psychosocially. As McHugh suggested above, part of the reason why is because sex change is impossible. It proves not easy nor wise to live in a counterfeit sexual garb. But why is the basis for the conclusion that sex change is impossible? Contrary to the claims of activists, sex isn't assigned at birth, and that's why it can't be reassigned. As I explain in When Harry Became Sally, sex is a bodily reality that can be recognized well before birth with ultrasound imaging. The sex of an organism is defined and identified by the way in which he or she is organized for sexual reproduction. This is just one manifestation of the fact that natural organization is the defining feature of an organism. As neuroscientists, as neuroscientist Maureen Kondik and her philosopher brother Samuel Kondik explain, in organisms, the various parts are organized to cooperatively interact for the welfare of the entirety as a whole. Organisms can exist at various levels, from microscopic single cells to sperm whales weighing many tons. Yet they are all characterized by the integrated function of parts for the sake of the whole. Male and female organisms have different parts that are functionally integrated for the sake of their whole and for the sake of a larger whole, their sexual union and reproduction. So, an organism's sex, as male or female, is identified by its organization for sexually reproductive acts. Sex as a status, male or female, is a recognition of the organization of a body that can engage in sex as an act. That organization isn't just the best way to figure out which sex you are. It's the only way to make sense of the concepts of male and female at all. What else could maleness or quote unquote femaleness even refer to, if not your basic physical capacity for one of two functions in sexual reproduction? The conceptual distinction between male and female based on reproductive organization provides the only coherent way to classify the two sexes. Apart from all that, all we have are stereotypes. This shouldn't be controversial. Sex is understood this way across sexually reproducing species. No one finds it particularly difficult, let alone controversial, to identify male and female members of the bovine species or the canine species. Farmers and breeders rely on this easy distinction for their livelihoods. It's only with respect to the human species that the very concept of sex has become controversial. And yet, in an expert dec in an yes, excuse me, let me repeat that. And yet, in an expert declaration to a federal district court in North Carolina concerning HB2, a state law governing access to sex-specific restrooms, Dr. Deanna Adkins stated, "From a medical perspective, The appropriate determinant of sex is gender identity. Adkins is a professor at Duke University School of Medicine and the director of the Duke Center for Child and Adolescent Gender Care, which opened in 2015. Adkins argues that gender identity is not only the preferred basis for determining sex, but the only medically supported determinant of sex. Every other method is bad science, she claims. It is counter to medical science to use chromosomes, hormones, internal reproductive organs, external genitalia, or secondary sex characteristics to override gender identity for purposes of classifying someone as male or female. In her sworn declaration to the court, Adkins called the standard account of sex an organism's sexual organization, um, an extremely outdated view of biological sex. Excuse me one second. Dr. Lawrence Mayer responded in his rebuttal declaration. This statement is stunning. I have searched dozens of references in biology, medicine, and genetics, even Wiki, and I can find no alternative scientific definition. In fact, the only reference to a more fluid definition of biological sex are in the social policy literature. Just so, Mayer is a scholar in residence in the Department of Psychiatry at the Johns Hopkins University School of Medicine and a professor of statistics and biostatistics at Arizona State University. Modern science shows that our sexual organization begins with our DNA and development in the womb, and that sex differences manifest themselves in many bodily systems and organs, all the way down to the molecular level. In other words, our physical organization for one of two functions in reproduction shapes us organically from the beginning of life at every level of our being. Cosmetic surgery and cross sex hormones can't change us into the opposite sex. They can affect appearances. They can stunt or damage some outward expressions of our reproductive organization, but they can't transform it. They can't turn us from one sex into the other. Scientifically speaking, transgender men are not biologically men, and transgender women are not biologically women. The claims to be contrary are not supported by a scintilla of scientific evidence, explains Mayer. Or, as Princeton philosopher Robert P. George put it, changing sexes is a metaphysical impossibility because it is a biological impossibility. Bear with me 1 second. I need a drink of water. All right. Sorry about that. The purpose of medicine, emotions, and the mind. It looks like I've got a couple messages here on stereo. I'm going to finish this up and then I'll play the messages. The purposes of medicine, emotions, and the mind. Behind the debates over therapies for people with gender dysphoria are two related questions. How do we define mental health and human flourishing? And what is the purpose of medicine, particularly psychiatry? Those general questions encompass more specific ones. If a man has an internal sense that he is a woman, is that just a variety of normal human functioning, or is it a psychopathology? Should we be concerned about this disconnection between feeling and reality, or only about the emotional distress or functional difficulties it may cause? What is the best way to help people with gender dysphoria manage their symptoms? By accepting their insistence that they are the opposite sex and supporting a surgical transition, or by encouraging them to recognize that their feelings are out of line with reality and learn how to identify with their bodies? All of these questions require philosophical analysis and worldview judgments about what quote unquote normal human functioning looks like and what the purpose of medicine is. Settling the debates over the proper response to gender dysphoria requires more than scientific and medical evidence. Medical science alone cannot tell us what the purpose of medicine is. Science cannot answer questions about meaning or purpose in a moral sense. It can tell us about the function of this or that bodily system, but it can't tell us what to do with that knowledge. It cannot tell us how human beings ought to act. Those are philosophical questions, as I explain in When Harry Became Sally. While medical science does not answer philosophical questions, every medical practitioner has a philosophical worldview, explicit or not. Some doctors may regard feelings and beliefs that are disconnected from reality as part of normal human functioning and not a source of concern unless they cause distress. Other doctors will regard those feelings and beliefs as dysfunctional in themselves, even if the planet does not find them distressing, because they indicate a defect in mental processes. But the assumption made by this or that psychiatrist for purpose of diagnosis, for purposes of diagnosis and treatment cannot settle the philosophical question: is it good or bad or neutral to harbor feelings and beliefs that are at odds with reality? Should we accept them as the last word or try to understand their causes and correct them, or at least mitigate their effects? While the current findings of medical science, as shown above, reveal poor psychosocial outcomes for people who have had sex reassignment therapies, that conclusion should not be where we stop. We must also look deeper for philosophical wisdom, starting with some basic truths about human well being and healthy functioning. We should begin by recognizing that sex reassignment is physically impossible. Our minds and senses function properly when they reveal to us and, and lead us to not truth. And we flourish as human beings when we embrace the truth and live in accordance with it. A person might find some emotional relief in embracing a falsehood, but doing so would not make him or her objectively better off. Living by a falsehood keeps us from flourishing fully, whether or not it also causes distress. The philosophical view of human well being is the foundation of a sound medical practice. Dr. Michelle Cretella, the president of the American College of Pediatricians, a group of doctors who formed their own professional guild in response to the politicization of the American Academy of Pediatrics, emphasizes that mental health care should be guided by norms grounded in reality, including the reality of the body itself. The norm for human development is for one's thoughts to align with physical reality and for one's gender identity to align with one's biological sex, she says. For human beings to flourish, they need to feel comfortable in their own bodies, readily identify with their sex, and believe that they are who they actually are. For children, especially, normal development and functioning require accepting their physical being and understanding their embodied selves as male or female. Unfortunately, many professionals now view healthcare, including mental health care, primarily as a means of fulfilling patients' desires, whatever those are. In the words of Leon Kass, a professor emeritus at the University of Chicago, today is a doctor and is often seen as nothing more than a highly competent hired syringe. The implicit and sometimes explicit model of the doctor patient relationship is one of contract. The physician, a highly competent hired syringe, as it were, sells his services on demand, restrained only by the law, though he is free to refuse his services if the patient is unwilling or unable to meet his fee. Here's the deal: for the patient, autonomy and service; for the doctor, money graced by the pleasure of giving the patient what he wants. If a patient wants to fix her nose or change his gender, determine the sex of an unborn child, or take euphoriant drugs just for kicks, the physician can and will go to work, provided that the price is right and that the contract is explicit about what happens if the customer isn't satisfied. This modern vision of medicine and medical professionals gets it wrong, says Cass. Professionals ought to profess their devotion to the purpose and ideals they serve. Teachers should be devoted to learning, lawyers to justice, clergy to things divine, and physicians to healing the sick, looking up health and wholeness. Healing is the central core of medicine, Cass writes. To heal, to make whole is the doctor's primary business. To provide the best possible care, serving the patient's medical interest requires an understanding of human wholeness and well being. Mental health care must be guided by a sound concept of human flourishing. The minimal standard of care should begin with a standard of normality. Cretella explains how this standard applies to mental health. One of the chief functions of the brain is to perceive physical reality. Thoughts that are in accordance with physical reality are normal. Thoughts that deviate from physical reality are abnormal, as well as potentially harmful to the individual or to others. This is true whether or not the individual who possesses the abnormal thoughts feels distress. That's important. Our brains and senses are designed to bring us into contact with reality, connecting us with the outside world and the reality of ourselves. Thoughts that disguise or distort reality are misguided and can cause harm. In When Harry Became Sally, I argue that we need to do a better job of helping people who face these struggles. So there it is, citing a definitive 30-year longitudinal study out of Sweden. There it is, the definitive mic drop moment, the end of the argument. There it is. The information has been delivered, folks, and it's not what is being parroted by what I call the lamestream media. All right, so I think we will go ahead and wrap up the YouTube stream here, and go ahead and